So we're going to talk about a bilateral internuclear ophthalmoplegia. And in the literature, it's sometimes referred to as WEBINO. And this WE stands for wall-eyed. And I don't like that term because it's pejorative, right? You're calling someone a wall-eye because they're looking at the wall. So I prefer the term EBINO, exotropic bilateral internuclear ophthalmoplegia. It's bilateral because it's a bilateral involvement of the medial longitudinal fasciculus. It's an INO because it's internuclear, and the two nuclei that it's between is cranial nerve nuclei number 6 to the contralateral cranial nerve nuclei number 3. And it's an ophthalmoplegia because it's paralysis or weakness of the eye muscles. So an internuclear ophthalmoplegia can be unilateral or bilateral. It can be associated with exotropia, which we call EBINO. So when you're looking clinically, the eyes are normally straight. And if you try and look to the left in this example, the right eye here might have a weak adduction. So the adduction is weak, and it can be either completely out, -4, or it could be -3 or -2, -1. It could just be slower, an adduction lag, we call that. And when you attempt to look to the left, you're going to get a dissociated horizontal abducting nystagmus. So it'll look like this. So this eye can't adduct, and the abducting eye is going to have a dissociated, only one eye jumping. So the combination of the dissociated horizontal abducting nystagmus and the adduction deficit is the characteristic clinical finding of the internuclear ophthalmoplegia, and it is from the lesion in the 6th nerve nucleus, which is the final common pathway for horizontal gaze in the pons. It has to talk to the contralateral 3rd nerve nucleus, and so that structure is called the medial because it's medial towards the center, towards the midline. It's longitudinal because it runs longitudinally, caudal to rostral. And it's a fasciculus, which is a white matter bundle in the central nervous system. So MLF, medial longitudinal fasciculus, cause INO, internuclear ophthalmoplegia. It can be unilateral or bilateral. In today's lesson, it's bilateral. And the reason it's bilateral is a lesion that affects a medial structure can ding out both MLFs because they're medial, and that means they're very close together. And so a demyelinating plaque that's in the center, medial, can cause a bilateral internuclear ophthalmoplegia, even though it's only one lesion. So bilateral lesions are necessary when lateral structures are involved, and a single lesion can cause a bilateral if it's medial. So a bilateral clinical finding can occur from a medial structure, but a bilateral clinical finding from a lateral structure actually probably requires 2 lesions or a non-localizing mechanism. So you should be thinking about INO with or without exotropia. If you have an adduction problem only, no ptosis, no up and down gaze palsy, no pupil involvement to suggest 3rd nerve palsy, it's going to be especially likely to be INO if the primary position they're straight. However, sometimes they're exotropic from decompensation of pre-existing phoria and the eye turns out. That can be an EBINO, an exotropic bilateral internuclear ophthalmoplegia. In a young person, you should be thinking about demyelinating disease. In an older person, it could still be stroke, especially if it's unilateral. And you should think about pseudo-INO. It looks like an INO, but it's not, and that most commonly caused by myasthenia gravis. So when you see this combination of clinical findings, adduction deficit, dissociated horizontal abducting nystagmus, think about INO. If it's on both directions, bilateral INO. If it's exotropic, EBINO versus pseudo EBINO, myasthenia. You need to do an MRI of that MLF and make sure that it's not demyelinating disease, a stroke, or a tumor at the level of the medial longitudinal fasciculus.